When we consider treating hepatorenal syndrome, we have to think about vasoconstriction. The pathophysiologic condition is such that in the setting of portal hypertension, we have too much blood going to the portal vein from the splanchnic bed within the abdominal cavity, which releases renin, aldosterone, diminishing effective renal perfusion. To reverse that, vasoconstriction is desirable, necessary, quite frankly. We have to vasoconstrict the renal artery. We have to vasoconstrict the splanchnic bed. There are a variety of vasoconstrictors out there with which you are familiar. Dopamine, commonly used in intensive care units, has absolutely no benefit, however, in the management of hepatorenal syndrome. Vasopressin can be useful. Quite frankly, it is vasopressin responsive vascular structures and peripheral structures that do respond to vasoconstrictors. However, vasopressin has the unfortunate tendency to add to volume expansion where we don't want it in these cirrhotic patients, and we wind up frequently having to go to more potent vasoconstrictors, which means we put patients in the ICU. In early cases of HRS, AKI, we hope to avoid that by intervening early before the creatinine is really out of hand at 2.5, 3 milligrams per deciliter. We'd like to keep them out of the ICU. We can use combination, as many of you probably have, midodrine and octreotide, and it is beneficial to a point. And the virtue of that, as I said, you stay out of the ICU. The midodrine gives you nice alpha agonist constriction of the kidney vasculature, and the octreotide constricts that big container of blood, the splanchnic circulation within the abdominal cavity. By constricting that, you lower portal pressures, reduce renin, better perfusing the kidney, and improving renal output, lowering portal pressures. Quite beneficial in the setting of hepatorenal syndrome and non-ICU care. Unfortunately, when that fails, as it frequently does, the patient is deteriorating. You have to get serious about vasopressors, and in the United States at least, the next step would be ICU transfer and the use of norepinephrine. In Europe and outside the US, otherwise, another drug, a vasopressin analog called terlipressin, has been in use for a number of years and has been very beneficial and can be used outside the ICU, but currently we do not have access to that, though hopefully in the near future that might change.